in the US. You can also see with the previous slide, please. The heroin graph below there, we saw an increase in heroin overdose deaths starting around 2006 as well, but they've actually remained relatively stable since then, a little bit of up and down, but no significant trend. And as Errol mentioned, national research has found that about 80% of heroin users reported using prescription opioids prior to heroin, but only a small fraction of those people who abuse pain relievers switch to heroin use. So less than 4% of people who had abused prescription opioids started using heroin within 5 years. However, given the number of people on prescription opioids, that's a pretty significant number. So our data suggests there isn't a lot of substitution happening here in Oregon of heroin replacing prescription opioids to the extent that it is in maybe some other states. Next slide. The other thing that we're concerned about is illicit fentanyl, which is a very potent synthetic opioid. You can see with this graph just the extent of the increase since 2014 when we first saw our first illicit fentanyl overdose. In 2017, there were 49 deaths due to fentanyl. Fentanyl is often mixed with heroin or other drugs with or without the user's knowledge, and it is very potent. So shifting gears a little bit here, talking about the Oregon Opioid Initiative. This is our framework that aims to reduce deaths, non-fatal overdoses, and harms to Oregonians from prescription opioids. And it's really got 4 components to it here. The first bucket there is reducing risk to patients, so emphasizing non-opioid treatments and non-pharmacological treatments for pain. The second bucket is reducing harms for people who are taking opioids and supporting recovery from substance use disorders. And then number 3 is protecting the community by trying to reduce the overall number of opioids that are in circulation. Underlying all those is data. So we're trying to optimize outcomes by making state and local data available for informing, monitoring, and evaluating our policies and interventions. So just to highlight a few of the things that are involved with these different categories in the Opioid Initiative. The HERC Health Evidence Review Commission prioritized list under that first bucket of reducing risk was adjusted to cover evidence-based non-opioid therapies for back pain as first-line treatment for Medicaid patients. Under the second bucket of reducing harms, those efforts have focused on increasing naloxone availability and education to reduce overdose deaths, and medication-assisted treatment to support recovery. Under the third bucket, which is reducing the number of pills in circulation, we focused on statewide prescribing guidelines and the Coordinated Care Organization Performance Improvement Project, which I'll discuss a little later. And then finally, under the data availability section, making data available to inform policies and programs, and the Opioid Dashboard is a big part of that. So I don't have time to go through this interactive dashboard with you, but I wanted to highlight that it's available. This is something that's available on the OHA website. If you Google Oregon Opioid Dashboard, you should find it right away. It's basically an interactive tool displaying controlled substance prescribing and drug overdose health outcomes. You can basically select state level, county level, or regional level data and display graphically various measures, including hospitalizations for various drugs, deaths, prescribing measures. And you can see that you can also see a map there for county level data for many of these measures. Next slide. So a little bit about our prescribing guidelines. We endorse the CDC guidelines, the foundation for opioid prescribing in Oregon. That focuses on non-opioid therapies for first-line treatment, establishing goals for pain and function before starting treatment, and discussion of benefits and risks between providers and patients. We know that the overdose risk doubles at doses of 20 to 49 morphine equivalent and increases 9-fold above 100. So the guidelines really do emphasize the lowest effective dosage. In Oregon specifically, we added some additions because we have legal marijuana here. We had additions focused on chronic legacy patients who trying to treat them compassionately and not just dismissing people because they may be opioid dependent. Offering naloxone in situations with a higher risk of overdose. The Oregon Prescription Drug Monitoring Program, where providers can review that to make sure they could determine whether a patient is at a high risk of overdose. And then the Material Risk Notice, which is a written document of the provider-patient discussion on long-term opioid therapy, including diagnosis, goals, alternative treatments, and risks. Okay, so supporting an education for prescribers. This is funded federally, and these are really ways that we are supporting providers around our changing standards of care. These can be confusing, and we want to make sure that patients aren't being left behind without appropriate treatment for their chronic pain. So this includes things like developing a toolkit for training of these guidelines, providing technical assistance and trainings to health systems and clinics, telepain for rural providers, which is a video conference method to connect specialists with rural providers who might not otherwise have that training. An Oregon Pain Commission pain training module, as well as regional opioid pain subnets, and OHSU's Project ECHO, also for rural providers. So what are the results of some of these efforts? This is data from 2015 to 2017 on Oregon opioid prescribing. And between the third quarter of 2015 and the third quarter of 2017, we saw a 24% decrease in Oregon opioid prescribing prescription fills. The Coordinated Care Organization Performance Improvement Project began in January 2016. All of the CCOs in the state are required to participate in this. And the measure was selected was monthly reporting of the percentage of the Oregon Health Plan enrollees who filled prescriptions of opioid medications above thresholds. And the two thresholds were 120 morphine equivalent doses and 90. And the 2018 measure will align with the new CDC guidelines and lower those to 50 and 90. So the results here for this measure, and this represents, again, a combination of public health and CCO efforts, a significant steady downward trend there since December 2015 in the percentage of Oregon Health Plan members on those very high doses of opioids. The next steps will be a new topic selection for 2019 to 2021, and a potential focus there is going to be on the acute to chronic opioid transition. So I just wanted to emphasize that our strategies that I've kind of highlighted here are kind of at the center of all these different needs, and it's really a challenge to balance them. We want to make sure that we're not ignoring any one of these. We want to make sure we're talking about patients and providers, the general public, legislators, and we can't ignore these, because if you focus on just one, you may see others worsen. So a little bit about the next steps here, changing the conversation. Again, the number one focus here is focusing on patient safety, function, and quality of life. We want to promote safer and more effective standards of care and pain management. We want to be compassionate and make sure patients are getting the treatment they need for their pain. Supporting recovery through MAT expansion, and also supporting the prescribers, as I mentioned, nurturing partnerships with the Oregon tribes, and again, public education, provider education, media campaigns. Those are all in the works. So it's really a multi-component effort here, and I guess we'll take questions at the end. So.
Are there any just quick questions for Dr. Jean in terms of data, just facts, data, things like that?
Dr. Jean.
I'm sorry, we're going to be taking audience.
I thought that you were asking them.
Yes, does the task force have any questions or any, need any clarifications or anything additional? Okay, thank you so much. Dr. Darnell? So Dr. Beth Darnell joins us from Stanford. She's been doing work